My name's Harrison Pearl. I'm a neurologist in Mobile, Alabama. I'm a stroke director at Mobile Infirmary Medical Center, part of Infirmary Health. It's around 500 and change bed hospital, one of the largest medical centers in the region. And I do all of the stroke and a lot of the neurocritical care here. And hand in hand with that goes quite a lot of epilepsy as well. Working with both patients with chronic strokes and different types of brain injuries, we see quite a bit of epilepsy here. So whenever I came here 2 to 3 years ago, we did not have any, we had routine EEG with the neurodiagnostics department, but we did not have any form of continuous EEG monitoring. We've been using Ceribell for a little over a year now, and we've had very good results from it. Been very impressed by the technology. And since the implementation of the Clarity software, it has really become a powerful piece of technology for us that, not only allows us to treat our patients more effectively, but allows us to work in a smarter way, not necessarily a harder way, because it really gives us very accurate results very quickly that can be seen at the bedside by nursing, and they can apply treatment. And this case is an example of that. A 74-year-old man who came in several days ago, he had a syncopal episode and was confused, but was at least interactive in the emergency department. And then at some point after his admission, he had a VFib arrest. He was resuscitated and put into hypothermia protocol. He went through rewarming and was on propofol, but whenever they got to target temperature and they began to hold his sedation, he was not interacting with examiners at all. He'd briefly open his eyes and close them again, but nothing purposeful. He was not fixating or tracking, and he was flaccid in all of his extremities. He was very, very sick. He's hypotensive on 3 vasopressors. Due to his hypertension, he went into acute renal failure. So there's multiple different specialties helping manage this patient, and we were consulted due to him not waking or interacting from sedation. He had a CT head that didn't show any acute findings. He couldn't have an MRI because of his pacemaker. And so then we started the Ceribell, and nearly immediately it began alarming for seizures. The nurse called me and told me, I'm trying to move to the hospital and see quite a few different acute neurologic injuries. So it's very helpful that the Ceribell gives bedside results without me having to actually get on and look at the EEG. And the nurse can call me and tell me that there's something going on. So I said to give Ativan, and the Ativan stopped for a few moments the abnormalities we were seeing on the EEG, but then they quickly came back again. And so we gave phosphonatoin, and it improved again for several hours. Later it would recur. Clarity software here provides a lot of visual information about how these build. That's one of the things for me about subclinical status epilepticus is how it evolves. It's not like a clinical diagnosis of epilepsy where we just look at the pre-ictal, ictal, post-ictal phases and use the chronology and symptoms to make a diagnosis. Here we're purely using EEG because the patient is essentially comatose. With no physical manifestation of any of this, no ventilator changes, no heart rate changes, nothing. It's not clearly continuous, but it never goes away for any clear period of time. So if we go to the first phosphonatoin dose, that's really where you see the background change. We still see a lot of these abnormal sharp waves with after going slow waves across both hemispheres occurring anywhere from up to 2 to 3 hertz, and then it'll dissipate for a few seconds and come back. And then as we go, after he was hypotensive, so this was very difficult to get him onto a significant dose of phosphonatoin safely, also with VFib arrest, with arrhythmia. But as we go on, all of a sudden the background really, all these discharges nearly dissipate, and now we're into just more of a general slowing. So just for me, just the response to treatment, the visual feedback that the Ceribell provides here is very useful in showing that this is an epileptic phenomenon that needs to be treated. The beauty of the Ceribell, at least for a private practicing neurologist, is that I can place orders in the chart saying if the EEG is flashing red, if the Ceribell is flashing red, reading continuous seizures, because I know that in this patient, this is going to be fairly accurate, we can go ahead and apply treatments, PRN treatments that the nurses can do. So there were periods of time at like, 12:30 in the morning, 1:30 in the morning, when the EEG the Ceribell is going off reading red for continuous seizures, and the nurses give Ativan and it shows complete cessation of the discharges. So we're able to provide the patient with treatment just based on nurse monitoring. And I think that gives a lot of fulfillment to the nurses at the bedside too, that become more involved with patient care. They feel like they are interpreting tests and applying treatment on their own. So I think it can really help in a lot of different ways for patient care.